Good morning. My name is Michael Wallace. I'm the current editor-in-chief of Gastrointestinal Endoscopy. It's my pleasure this morning to interview Dr. Sachin Wani, professor of medicine at the University of Colorado and also the chair of the ASG Standards of Practice Committee. We had the opportunity this morning to talk about our new Barrett's esophagus guidelines. Dr. Wani's committee chaired those guidelines, and so this is a perfect time as they've just come out this month. Sachin, spend a couple of minutes telling us about the process for the guidelines. I know you've made some significant changes in how we create our guidelines. Tell us about that first.
Absolutely, Mike. It's an absolute honor to be here this morning, and I do want to say that I do represent our entire committee this morning. We really do put in a lot of effort to produce these guidelines, and I think as all of our members understand, our clinical practice guidelines really play a pivotal role in our healthcare delivery. There have been a few changes that we've made as a committee. For one of our goals and missions always as a committee and society is to produce documents that are completely transparent, that are actionable, and most importantly produced with the highest methodological rigor. We've moved towards ensuring that every document actually meets the National Guideline Clearinghouse criterion. We've also started using the GRADE framework. As you're aware, more than 100 organizations actually use the GRADE framework to produce their guideline documents. I will submit to you not every document coming out from our society or our committee will be produced using the GRADE framework, but at the bare minimum, they'll meet the NGC criterion. This really involves ensuring, again, being completely transparent about the process, performing a systematic review and documenting the search strategy that we used for our documents. I do want to spend a minute or two talking a little bit about the GRADE framework. It really starts with the governing board approving the document and the questions that our document will address. The next step is to actually create our questions using a PICO format, as our audience is aware, that really addresses the population, the intervention, the comparator, and the outcomes. And we really focus as much as possible on patient-centered outcomes. The next step is for us to perform a systematic review on the published literature. We look at the quality of evidence and certainty of evidence. And then based on all these criteria, we draft our recommendations. It's also important to note that it's not just these factors that play a role in our final recommendations. Our GRADE panel always includes a patient representative, so taking into account what our patients feel about these guidelines is critical. We look at the cost effectiveness and the risk-benefit ratio. So we're really excited about this new path that we've taken with our guideline documents, and we're really proud to present our first GRADE document, which I think we'll be talking about.
Well, I appreciate all that incredibly hard work. I know, being somewhat involved in it, that it really requires a lot of extra steps to achieve that high standard of quality. I'm also very glad to see them published in GIE. We've made a couple of small changes, as you know. We now clearly indicate that this is a guideline, using guidelines in the title, so our users can very rapidly find what really are the most important society documents that define our standards of practice. Let's now turn to the content of the guidelines. Maybe if you could summarize the key recommendations, maybe beginning with the requirements for expert pathology review and just the general role of endoscopic eradication therapy for high-grade and low-grade dysplasia.
Absolutely. So the process started with us identifying 7 key issues with regards to endoscopic eradication therapy for patients with Barrett's-related neoplasia. And Mike, you bring up such an important aspect of this management, which is ensuring that we confirm the diagnosis of dysplasia by an expert pathologist or a panel of pathologists. And the data supporting this recommendation really stems from multiple high-quality observational studies suggesting the inter-observer variability amongst our pathologists, not just at tertiary care centers such as ours, but also in community practices. We've also shown in a systematic review that we did for this specific document that an expert pathology review results in a change in diagnosis in nearly 55% of cases, vast majority of which, as you know, were cases that were diagnosed initially as indefinite for dysplasia or low-grade dysplasia. So we think this is an important aspect before you actually embark on endoscopic eradication therapy. The two other critical questions that you brought up, Mike, with regards to management of Barrett's related neoplasia is how do you manage patients with high-grade dysplasia and low-grade dysplasia? And the comparator here is surveillance. I think we have good efficacy data from randomized control trials such as the AIM dysplasia trial and the SURF study demonstrating the efficacy of endoscopic eradication therapy for this subgroup of patients. We also have good effectiveness data demonstrating our ability to achieve complete eradication and reducing the risk of progression in these patients. So based on this available literature, we strongly recommend against surveillance for patients with high-grade dysplasia. For patients with low-grade dysplasia, given all the controversies, we've really taken a pragmatic approach. We still do recommend, or at least suggest, endoscopic eradication therapy for those patients with confirmed low-grade dysplasia, but we do take into account patient values into this recommendation. So for patients who place a high value on avoiding adverse events related to endoscopic eradication therapy, we as a society and as a committee feel it's perfectly okay to enroll them in surveillance programs.
And the key word seems to be that confirmed dysplasia. Now that low grade is the trigger for therapy,
right.
We also know that that has to be confirmed because the majority of those end up, when they're re-reviewed, being downgraded.
Absolutely. And there's good data now suggesting that the number of pathologists agreeing on the diagnosis of dysplasia is actually a predictor for progression to high-grade dysplasia or cancer. So really compelling data.
Is there still a role for surgery for high-grade or intramucosal carcinoma? 10 years ago, we sent these patients for esophagectomy. Do we send any of them now?
Yeah, no, so I think this was also one of our PICO questions, and we strongly actually recommend against surgery for patients with high-grade dysplasia or cancer. Now, when you provide a strong recommendation, that really needs to be backed up by high quality evidence, but I think we all know that there's really no randomized control trial comparing endoscopic eradication therapy to surgery for patients with high-grade dysplasia or cancer. But our strong recommendation is really based on avoiding the adverse events associated with esophagectomy. Not only that, we have good observational data suggesting comparable 5-year outcomes for patients undergoing surgery compared to those undergoing endoscopic eradication therapy. So I think we're on solid ground when we make this recommendation against surgery. And as I tell my trainees, you really need to think, when you do get into independent practice, you really need to think at least 10 times before you refer a patient with high-grade dysplasia or cancer for an esophagectomy.
And in particular, it's the intramucosal cancer's invasion into the mucosa. I know there's some controversy when there's a little bit of submucosal invasion, but even that superficial submucosal invasion, if it overall looks histologically differentiated with no other poor features, that those are also okay for endoscopic therapy?
And we did not specifically address patients with submucosal cancer, but you're absolutely right. This field is evolving. There may be a subgroup of patients with submucosal cancer who may do just fine with endoscopic eradication therapy.
Good. Yeah. Let's talk a little bit about the role of EMR. Which lesions should you EMR, and the balance between EMR and the ablation therapies? How do we choose where to EMR? Should we just EMR the whole Barrett's out? What does the guideline say?
Yeah, no, I think again, critical aspects for achieving optimal outcomes for patients undergoing endoscopic eradication therapy. I think this document clearly states that if you have any visible lesion, you've got to perform endoscopic mucosal resection. We gave this a strong recommendation based on moderate quality of evidence, and this really is based on, again, multiple studies demonstrating that when you perform an endoscopic mucosal resection, you actually change your diagnosis, you change the grade of dysplasia, and it really is a critical step if you're going to decide if you're going to continue endoscopic eradication therapy or surveillance, or refer that patient for an esophagectomy. So based on our systematic review, 40% of patients, when they undergo an EMR, you actually see a change in diagnosis. Now, with regards to performing EMR followed by ablation for our patients with Barrett's-related neoplasia, compared to performing EMR of the entire Barrett segment, we again gave this a strong recommendation and recommend performing EMR with ablation compared to EMR of the entire Barrett segment. And again, we took into account the risks involved with performing EMR of the entire Barrett segment. The risks really outweigh the benefits. As you're aware, the risk of strictures is prohibitively high when you perform EMR of the entire Barrett segment. And we have data from, again, efficacy studies, as well as a randomized control trial showing that you have comparable outcomes with regards to these two approaches, and a much higher rate of strictures and higher number of endoscopies required in the arm that gets treated with EMR of the entire Barrett segment.
Is there a group that should get EMR of the whole segment? Maybe a very short segment where the nodule represents the majority of the actual Barrett's? Or we see some patients who really have diffuse nodularity, and we're concerned about doing ablation of that nodular disease.
Completely agree with you, and I've seen that in my practice as you have in yours, Mike. There are some cases where I'm just not comfortable not performing EMR for the entire Barrett's, and we do talk a little bit about, it's not a separate PICO question in our guideline document, but we do talk about the caveats about this recommendation, and we state categorically in our document that there may be a few patients who may still benefit from performing EMR of the entire Barrett's, and what you pointed out is spot on. Those patients with diffuse nodularity should definitely be considered for complete EMR of the Barrett segment.
Good. Well, it's really impressive to me how both thorough and how practical these guidelines are. It's really a significant step forward for the society and our Standards of Practice Committee. So, Sachin, congratulations again. This is really a terrific effort, and I know all of our ASG members and broadly will really benefit from this new guideline. Thank you.
Thank you so much, Mike. I really appreciate the opportunity to talk about our guidelines.
Good. Thank you.